Dr. Debra Budiani-Saberi to make a presentation. Dr. Saberi is a medical anthropologist, the executive director and founder of the Coalition for Organ Failure Solutions. She has conducted extensive research related to organ trafficking beginning in 1999 as a part of her study on refugee health. Her work has included an analysis of key stakeholders and actors involved in the organ trade, including victims, recipients, medical professionals, religious clerics, laboratories, and the state. She has provided consultation on organ trafficking to the World Health Organization, United Nations Office of Drugs and Crime, and has worked in alliance with various medical and civil society organizations to combat organ trade. Thank you.
Thank you, Annalisa, for organizing this event. As this issue has been close to our hearts at the Coalition for Organ Failure Solutions, I can think of few more special ways to spend Valentine's Day, so thank you. It's an honor and pleasure to be here, and especially to move responses forward to this problem as we at COFS continue on the ground to see how brokers develop increasingly clever and abusive methods. And thank you, Dr. Rothman. It's refreshing to be reminded that it was a human rights entry that alerted you to cases. As our talk today reflects, it's become particularly challenging to advance a human rights approach now to our evidence-based findings and others' findings of cases. I'd like to also introduce Sean Colomb, who will present with me today. Sean is at Queen's University in Belfast and is a project assistant at COFS and brings a background in human rights and law to the issue. So by way of brief introduction of how I stumbled upon this issue, in 1999, when I discovered unanimously shared fear of organ theft amongst 300 plus asylum seekers from the Horn of Africa and Egypt. Since then, I worked to unravel the exaggeration in some of the details of their fears from the realities of abuses inflicted upon these and other vulnerable groups for an organ removal in Egypt, in the Middle East, elsewhere in the Middle East as well, and in Asia. I founded COFS in 1995 as a vehicle for which a path could be paved for research, advocacy, and activism on this issue. So COFS is a nonprofit international health and human rights organization with a mission to combat organ trafficking and provide outreach to victims of the organ trade. We've identified over 1,000 victims of human trafficking for an organ removal, what we call HTOR, and conducted in-depth interviews and provided outreach assistance for approximately 300 of them. So, and this is a slide of our reports where some of the evidence-based findings are captured. So in so doing, we start with the premise that socioeconomic conditions should not be the determinants for an organ donation. So various initiatives, some of which Dr. Rothman captured, have created better recognition of HTOR and have worked to reduce it since the mid-1980s. Yet the organ trade still thrives in many countries and will continue to challenge opposition measures as the demand for organs continues to outpace supplies. Improved laws related to transplantation are an important element and a wonderful accomplishment by various initiatives. However, as we have seen in various countries where we're on the ground, even sophisticated legal frameworks on transplantation have loopholes that enable violations and complicate law enforcement. Centering anti-HTOR efforts within a human rights framework, an analysis in response to this problem is enforced by initiatives on other key forms of human trafficking, i.e. sex and labor. Such an approach enables us to mobilize and employ various legal instruments to better elicit additional state and international responses to further tackle the violations. It also requires us to consider how various measures impact or disregard victims and potential victims of HTOR and to better advocate their interests, rights, and freedoms. Accordingly, we will first briefly discuss several key concepts and terms, then briefly review a background of international responses, and if you can, yes, the next slide. Finally, argue that a human rights-based approach should be employed to ensure that HTOR is not reduced to a problem of supply and demand, of organized crime and criminal justice, or of voiceless and abandoned victims, but rather maintains a focus with victims and survivors of HTOR and the advocacy of their interests at the center. So this is a rather simplified map of key countries that host the organ trade in red, and then client countries to the organ trade in yellow. In the interest of time, we will skip a detailed discussion of the problem of organ trafficking and its scope, but I'd be happy to discuss this in the Q&A if there's an interest. So with reference then to key terms and concepts, it's important to first clarify that the definition of organ trafficking first established by the Istanbul Declaration is directly derived from the UN Human Trafficking Protocol. And I have the definition on this slide. The Istanbul Declaration's definition of organ trafficking is thus largely harmonious with the definition of trafficking for the purpose of the removal of organs, as articulated in the UN Trafficking Protocol. The cases that are generally considered in discussions on organ trafficking, and in every case that COFS has addressed, are within the definition of UN Trafficking Protocol for the purpose of an organ removal. However, it's important to address three misconceptions in the literature and discourse on this issue that we believe have impeded responses to it. The first misconception is that there is a distinction between trafficking in organs versus HTOR. Although tissues and cells remain viable for longer periods and commonly travel independent of their donors, organs are largely not transported independent of persons in commercial transplants. Upon removal, they are transplanted. Thus, most abuses occur when organ is removed from a victim within a location where the recipient awaits and the transplant is performed. However, preservation techniques certainly make the independent transporting of organs possible presently, and practice is likely to increase across the globe in the future. Nevertheless, even if organs are transported independently in countries where commercial transplants are commonly practiced, a person most likely was trafficked in order to remove that organ. Therefore, such instances should still be considered HTOR whether or not that organ was transported independently after the removal. And this misconception has been expressed in major anti-trafficking initiatives, and from the ground, this is a misconception we're happy to address and discuss. Another misconception is that if consent is obtained versus coercion for an organ removal, that it's not trafficking or human rights abuse. In all cases that COFS has encountered in which consent is claimed, the individual's vulnerability has been exploited. That is, individuals have agreed to something they would not have otherwise if conditions were less pressing. As in other forms of human trafficking, when any of the improper means of trafficking are established, consent is rendered irrelevant and consent-based offenses cannot be raised. So while explicit threats or use of force of coercion for an organ removal are employed in some cases, clever traffickers do not use violence and force, but rather use manipulative methods to obtain an organ. The majority of cases thus involve implicit coercive measures and or the variety of other means included in the UN Trafficking Protocol, namely fraud, deception, the giving of payments or benefits, and the abuse of power or vulnerability to obtain consent for the removal of an organ. For example, COFS has worked to show how Sudanese asylum seekers who fled genocide in Darfur in Egypt are put into situations in which smugglers who assisted them to cross the border later provide food and housing for them in Cairo and then demand exorbitant sums for this assistance. Smugglers collaborate with kidney traffickers to suggest the idea of a kidney sale as a way to remedy the financial problem. COFS has worked also to show that debt collectors in India who suggest a kidney sale to settle a debt also often suggest that the indebted target would want to see that their family remains safe. Organ traffickers typically do not explain risks and often do not complete or make the payments after the kidney removal. A final misconception is in regards to payment. The UN Trafficking Protocol stipulates that the receipt of payments or benefits does not exclude cases from being exploitative, in this case foreign organ. Just as an individual trafficked for domestic servitude may get paid and still be rendered a victim of trafficking, it is not payment or the amount of money that is relevant, but rather an individual's position of vulnerability that is manipulated and controlled for the purpose of labor, and in other cases for sex or an organ, for sex or labor, or in this case for an organ. Similarly, in situations of debt, bondage, or bonded labor, consent and payment do not deem the practice legally permissible. I'd like to next briefly talk about some of the responses to this issue by briefly first mentioning the response of the WHO. So since 1987, the 40th World Health Assembly endorsed several resolutions which form the WHO guiding principles on human organ transplantation. These principles outline a framework for living and deceased organ donation to increase organ supplies, and while prohibiting the giving or receiving of material gain in exchange for an organ. And various versions have been developed and enhanced since then. A response from the International Transplantation Society and International Society of Nephrology was that to develop the Istanbul Declaration, which includes a set of principles to guide transplant practices to prevent the organ trade. The definition of organ trafficking in the Istanbul Declaration speaks to exploitation that can drive an organ removal and was not intended for prosecution purposes, as is the definition of trafficking offense outlined above in the Trafficking Protocol. The declaration emphasized donor safety and notes that a positive outcome for recipient can never justify harm to a live donor. So as with the WHO guiding principles, organ trafficking is in the main represented as an issue of supply and demand. Another response has been from that of the criminal justice world, namely UNODC, as the UN Trafficking Protocol was the first multilateral treaty to explicitly recognize H2OR as a practice that should be criminalized and punished. As such, it was established by the UNODC. As discussed above, under the terms of the protocol, the offense of trafficking can only be established where an action followed by means for the purpose of exploitation, and in this case, removal of organs, can be proven. And finally, a key response has been from fieldwork and civil society. In addition to these initiatives by UN agencies and medical societies, over the course of the last decade, there have been also significant field-based inquiries from social scientists, journalists, transplant professionals, and other health and human rights activists. As captured in the following table, their research and reports have provided evidence of how these abuses have been organized, the inter-country and transnational reach of coordinating victims of H2R with patients in transplant centers, and victims' long-lasting consequences. And I'd like to emphasize the importance of recognizing that the abuse should be recognized similarly whether it's a domestic organ trafficking case or one that crosses borders or not. So several of these parties have organized initiatives to conduct studies on victims of H2R. Some have included a medical follow-up service. However, researchers have generally not arranged care provision after obtaining the study's findings. COFS has aimed to provide victim assistance to include ongoing medical follow-up, as well as health education, counseling, peer support, employment assistance, and referrals to legal services or legal aid. This range of services has become standard for victims of sex and labor trafficking, typically delivered by state-supported and/or private victim support agencies. Yet the UN has continued to struggle with distinguishing H2R from organ trafficking, and many countries have not yet included H2R into their trafficking laws, their domestic trafficking laws, including the US. Consequently, I'll add that in recent briefings on Capitol Hill, there's been some willingness expressed from particularly Congressman Christopher Smith's office, and so it's something we've been trying to address within the US better to improve domestic law. So this range of, consequently, adequate resources have not been committed, either at the international or national level, to provide support services to victims of H2R. So while COFS has identified thousands of victims of H2R, it has only had the capacity to provide outreach to several hundred of them in very few countries. Further protection measures developed for victims of other forms of human trafficking largely do not exist for victims. I had several key recommendations to make, but I'll just end with one. We have recommendations for international community and health organizations, but I'll end with just reiterating that the loopholes in domestic transplant laws allow for trafficked persons to be perceived as willing participants in commercial transplants, and these must be redressed. So apart from consent procedures, we recommend that a third party serve as an advocate for potential organ donors to assess their vulnerability through a trafficking lens. And although we didn't get to talk about transplant tourism as much, states should also develop domestic legislation to prohibit it. Namely, almost every state across the globe has a domestic law that prohibits the buying and selling of organs, that should extend the jurisdiction of these laws to ban citizens and residents from purchasing an organ outside its borders, so that patients in North America or Europe should be prohibited from going to Mexico, China, or the Philippines, and so on. So with that, thank you so much.